will be posted on the BC Renal website, so you can review it at your leisure or share it with others, which we certainly highly promote. Next slide. So we're hosting this session on the unceded ancestral territory of the Coast Salish peoples, and that includes the territories of the Musqueam, the Squamish, the Tsleil-Waututh Nations, and the Métis Charty community of the Lower Mainland. I think as a community, we understand the relationship between the land, environmental health, and kidney health, and the importance of respecting all and helping to tend to both kidneys and the land so that we can improve the longevity of both. And there are a lot of lessons to learn from our Indigenous colleagues. And we certainly try and do more and more things in the spirit of truth and reconciliation to make this a meaningful moment and a meaningful collaboration between all of us as we go forward. Next slide. So a reminder that province-wide rounds is a unique collaboration between BC Renal and the University of British Columbia Division of Nephrology. We have multiple industry partners that make these rounds possible, but importantly, you in all of the different health authorities are also a major part of making these rounds successful, both by your attendance as well as your questions, and then of course by taking the knowledge that we learn here and moving it forward into practice. So for that, we really thank you all. And so with that, I'd like to hand it over to Dr. Gill to introduce our speaker on the topic. Next slide.
Thanks very much, Adira, and welcome to everyone. I hope everyone had a great summer. So I'd like to welcome everybody to our first transplant session of the year with something that, as many of you appreciate, is near and dear to us in our province, which is living kidney donation. Now, many of you know we've had a history of success and innovation in living donation in British Columbia. But as you'll hear in the talk today, there's challenges that we're facing that we haven't faced before, and it's time for us to kind of move towards the next step in our current realities. Speaking today is Dr. Justin Gill, who, as I think most of you know, has joined us as a transplant nephrologist at St. Paul's Hospital in 2020 after completing his internal medicine and nephrology training at UBC and his transplant training at Emory University in Georgia. In addition to being an exceptional transplant physician, Justin's a trained clinical bioethicist, which brings a really interesting lens to a lot of the work that we do. The other distinction is, of course, he is a J. Gill, and he's officially moved me into middle child category in our group now. Justin's going to talk about a very interesting topic related to living donation and an initiative called Donate Now. So without further ado, Justin, take it away.
Perfect. Thanks so much, Jag, for that kind introduction, and Adira for the introduction as well and inviting me to speak today. Morning, everybody. Thank you for getting up early on the first rounds of the year to listen to me speak. This is a really exciting time in living kidney donation in British Columbia, and I'm really looking forward to telling you all about Donate Now, which is a unique reciprocity-based strategy to increase living kidney donation in British Columbia. We'll be going through a little bit of the history around reciprocity-based strategies and what that means and how that's increased living kidney donation in the past, both locally and internationally. And then I'll be segueing into talking more about the policy that we plan to launch ideally in 2025. So no conflicts of interest and no financial disclosures on my part. So our objectives, as I mentioned, are to review reciprocity-based strategies in organ donation and transplantation, to describe the ethical and legal considerations in implementing a reciprocity-based strategy to increase living kidney donation, and then finally to outline the Donate Now pilot program initiative. So by way of background, it's no surprise to anybody likely on this call that renal transplantation for patients with end-stage kidney disease offers an improvement in quality of life and a potential increase in life expectancy. Renal transplantation is cost-effective to the healthcare system. The publication there by Clarenbeck and Mann that was published in 2009 showed that over 5 years, every 100 kidney transplants saves our healthcare system here in Canada approximately $14.6 million, and that's in US dollars. So if we were to translate that to current day Canadian dollars, that would be quite a bit more. And that's primarily driven by averted dialysis costs. So clearly, the impetus is to get people transplanted as quickly as possible and to get them off of dialysis. Living donor transplantation is advantageous for recipients compared to deceased donor transplantation with respect to improved graft and patient survival. However, despite all of this, there continues to be a mismatch between the supply of available organs for transplantation and the demand for transplantation. And this ultimately leads to death on the wait list, which is really what we want to be preventing here. And so the transplant community has consistently put efforts into improving the number of available organs for transplantation. And we're going to outline some of those initiatives that have been used in the past, and then also outline the new initiative that we're hoping will also improve the supply of available organs for us going forward. So by way of background, as I mentioned, the demand for transplantation is big, and it continues to rise in Canada as the number of patients living with end-stage kidney failure in our country continues to increase year after year. So if you look at this is core data from 2023, and we've had a 17% increase in the number of incident patients receiving renal replacement therapy over the last 10 years. And therefore, we need to improve the number of patients who are receiving a preemptive transplant, which is denoted by the small blue triangles at the bottom here. That's been relatively stagnant, and preemptive transplantation in this country happens through living kidney donation and living kidney donor transplantation. And as you can see, most incident patients are starting on hemodialysis, followed by peritoneal dialysis, and the lowest amount that's been quite stagnant over the last decade has been the preemptive living donor kidney transplants. Here in BC, just to highlight the data locally, we continue to see increases in our number of patients with end-stage kidney disease. As of December 31st of 2023, we had a total of over 22,000 patients registered with chronic kidney disease, either pre-dialysis or on a form of renal replacement therapy. To me, this is a staggering number of patients, and many of whom will ultimately be considered for transplantation and referred for transplantation. And so clearly, with the growth of the population with end-stage kidney disease, we're also going to be seeing growth in our transplant population and the people that are being referred for consideration of a transplant. So concording with the increase in the number of patients with end-stage kidney disease, we've generally seen an increase in our total transplant activity over the last decade. Jag already mentioned our great successes within living kidney donation and living kidney donor transplantation. But despite our increase in overall transplant activity, unfortunately, we're seeing that living donor transplant rates are declining. And the absolute number of living donor kidney transplants has declined significantly since pre-pandemic. You can see here that from 2015 to 2019, there was close to 100 to 120 living kidney donor transplants per year. And since that time, we've dropped off significantly in terms of the number of living donor kidney transplants. May have been an effect of the pandemic, but we're now coming out of that and are hopeful that we're hopeful that the living kidney donor numbers would have rebounded by now, but have seen sort of stagnant numbers since the pandemic. So not only is the absolute number of living kidney donor transplants going down, but we're actually seeing the rate of living kidney donor transplantation decline over time. So in 2015, it represented 40% of our total transplant activity. Now in 2023, it was down to 22% of our total transplant activity. This is representing the same data graphically. Living donor transplantation here is highlighted in light blue and deceased donor in orange. As you can see from the proportion of kidney transplants per year that are coming from living kidney donors, this is decreasing with time because the blue bar is basically reducing as time goes on. Now, this is all despite the fact that there's more literature showing excellent health outcomes for living kidney donors, both short and long term. And that's allowed programs like us to become less restrictive on our candidacy for living kidney donation. So we're routinely accepting individuals who are of older age, who have certain managed comorbidities, for example, like hypertension. But ultimately, as mentioned, this is the optimal mode of transplantation as well for our recipients in terms of morbidity and mortality risk to a patient, as well as for allograft longevity. So this has called us to really look at what we can do to bring our living donor kidney transplant numbers up in our program, because certainly something needs to change, and we want to get at least back to pre-pandemic levels and certainly try to exceed that if at all possible. And just to highlight, this is not just a BC issue with living kidney donation. On a national basis, you can see that the number of living donor kidney transplants, which are donated by the blue square here at the bottom, that's remained relatively stagnant over the last decade, with subsequent increases in deceased donor numbers. And so also warrants an examination on a national basis as to why our living kidney donor numbers are stagnant and what we can do to advance initiatives nationally to increase living donor transplantation. So now the golden question is, how do we increase living kidney donation? How can we increase living kidney donation to increase the supply of available organs, but also to improve the health outcomes of our kidney transplant recipients and keep people off of dialysis for longer periods of time? So this can be broken down into initiatives that are directed at recipients and initiatives that are directed at donors. For recipients, there's been a significant push for education, and many of the people on this call will know that there's been a big educational push within our kidney care clinics and through the transplant program with various educational materials in various languages, community outreach groups, information sessions, etc. And that's been to, we've tried to increase the supports and identify barriers to living kidney donor outreach for recipients for quite some time now. There was an excellent study that, if you haven't read it yet, you should. It's a Canadian study that was published in JAMA last year by Garg et al. Called the ENACT LKD trial. Unfortunately, this didn't really yield promising results when we look at our ability to increase living kidney donation through recipient-directed initiatives. So this was a novel multi-component intervention that looked at targeting barriers preventing eligible recipients from completing key steps in the transplant process. One of the key steps being living kidney donor outreach. And patients were randomized to two groups: those who received the intervention, so those who went through the novel multi-component intervention, and those who received the present standard of care with the present educational materials that were offered through the program. Unfortunately, this study was ultimately negative, and it showed that novel multi-component intervention did not significantly increase the rate at which people completed steps towards kidney transplant, including one of the steps being living donor outreach, living donor registrations, and subsequently living donor transplant. So as a kidney transplant group, this sort of tells us to potentially focus our initiatives more towards donor-directed initiatives rather than recipient-directed initiatives based on the results of that trial. So when we look at initiatives directed at a donor, the American Society of Transplant and the American Society of Transplant Surgeons actually convened a workshop back in 2015 to explore increasing living and deceased donor organ transplantation in the United States. And ultimately, it was thought that what they called an arc of change was the best way to approach improving access to living donor transplant. This begins with removing existing disincentives that might impede people from donating their organs before ever considering the possibility of introducing any sort of incentive for organ donation, because incentives get quite murky. And so we wanted to make sure that as a community, we're removing all major disincentives to living kidney donation, and that's become the priority for various initiatives, which I'm going to outline shortly. One major disincentive for donors in the past was the cost of being a living kidney donor. Central to improving our access to transplant right now in the community is provision of financial neutrality for our donors. This means ideally that a donor should not incur significant costs from transplant, nor should they gain any money from transplant. So they should remain ideally financially neutral. So the Living Organ Donation Expense Reimbursement Program is administered by the Kidney Foundation of Canada to reimburse donors for eligible expenses, things like travel, parking, accommodation, meals, etc., but also potential loss of income. But ultimately, through this program, patients can still incur some cost. And so there needed to be some novel initiatives to look at how we improve the fact that people that organ donation is financially neutral for donors. And so most employers haven't yet established policies to provide coverage for lost wages, but this initiative called the Canadian Society of Transplant Living Donor Circle of Excellence, which is in collaboration with the American Society of Transplant. This aims to eliminate the financial costs of living organ donation by providing lost wages. So a minimum 80% salary support for a minimum of 4 weeks for living kidney donors. And so if companies participate in this, they get recognition in terms of annual certificates from the Canadian Society of Transplant, recognition on the CST website and social media platforms, and promotion at various transplant meetings and events. And this initiative was actually led by John Gill, and has been very successful at furthering financial neutrality for our living kidney donors. Now, in addition to financial neutrality, another major disincentive to living kidney donation was immunologic incompatibility. And ultimately, through the kidney pair donation program, the possibility that people would be able to donate their kidneys to somebody else was, and then another individual to donate their kidney to the intended recipient. That then provided a solution to the fact that people could not donate directly to their intended recipient. And so the KPD program that's run through Canadian Blood Services is a national program, and it allows identification of suitable matches for transplant candidates who have potential living kidney donors that may not be able to directly donate to them. What's amazing is that the KPD program has facilitated over 1,000 kidney transplants now since its inception across the country. And those are transplants that wouldn't have happened if we didn't have a national organ sharing system that was in place necessarily. And so kidneys now fly to recipient destinations, and donor nephrectomies now happen in home centers. The pandemic pushed us to basically not have donors flying to a recipient center, which we used to do. And now donor nephrectomies happen at a donor's home center, and the kidney ends up flying to the recipient center. And so this has also removed a disincentive that some donors didn't want to travel to donate their kidneys to another city. So this has been these are two examples of how we've, as a transplant community, removed significant disincentives to living kidney donation. Now, another way to remove disincentives is through something called reciprocity-based strategies. And in human behavioral ethics and academics, reciprocity plays a significant role in what we call social stability. In reciprocity, there's an exchange between two parties, but it's not simply an altruistic exchange or a gift exchange. There is some sort of other potential motivating factor that might provide assurance or a potential benefit at some point to each member of the exchange. So in organ transplantation, reciprocity indicates that a living donor, for example, might receive some tangible assurance from organ donation programs about their own future or about the futures of individuals in their community that they might be worried about. In essence, if anybody knows about nudge theory in ethics and academics, nudge theory in organ donation is when individuals who are already predisposed to donate a kidney are promoted to do so by various what they call nudges or subtle cues within their environment, or through subtle cues and initiatives. And primarily those subtle cues either put the person in the context of an individual who needs an organ transplant. So you might have seen sort of posters that say, what if you needed a kidney? And it causes people to reflect on that. But nudge theory in reciprocity-based strategies also provides assurances about their own future and about the future of people that they might care for, that reassure a donor and sort of promote them to pursue the action of living kidney donation that they were already predisposed to. So in BC, the way that we have instituted a reciprocity-based strategy is that we've historically prioritized all past living kidney donors for deceased donor organ transplantation, should they require a kidney transplant themselves in the future. Now, this is clearly a very rare event, but it does provide donors with the assurance that they will be acknowledged for their past donation in their priority. And as you can see here, these are our current priority groups in terms of highest priority at the top and lowest priority at the bottom. As you can see here, there are various priorities that usurp previous living kidney donors. For example, medically urgent individuals, so those running out of dialysis access, highly sensitized patients, patients who are receiving multi-organ transplants, so combined kidney heart, kidney lung, and kidney liver, pediatric patients, simultaneous kidney pancreas transplant patients on dialysis, and then prior living kidney donors who might have developed end-stage kidney failure for any reason. And then the last in the priority list currently is a pre-emptive, so meaning before they start dialysis, simultaneous kidney pancreas transplant. And these are the priority groups that are above the current general wait list. So in addition to that's what we have locally in terms of reciprocity-based strategies that have increased living kidney donation. Internationally, however, there's been more sort of bold initiatives that have been undertaken. And perhaps the most renowned example of this is Israel's 2008 organ transplant law, where the Israel Ministry of Health adopted a program of a priority point system for organ allocation. And the goal of this was to increase the number of living and deceased organ donors. The priority policy is innovative and was the first of its kind internationally in sort of marrying living and deceased organ donation and transplantation. So the way that they assign the points priority system, maximum priority is given to an individual in need of an organ transplant who had a first degree family member who was already a cadaveric donor, or who they themselves was a living organ donor themselves. So very similar to what we have here in terms of prioritizing prior living kidney donors, but maximum priority is also given if you have a first degree relative that donated organs after their death. The second tier of priority is given, or what they call regular priority, is given to a registered organ donor who's been registered for at least 3 years by the time that they themselves need an organ transplant. And then finally, the second priority tier is a first degree relative who's registered as an organ donor. And so, as you can see, excuse me, as you can see here, this is pretty novel in that it's giving priority not just based on somebody's own living kidney donation, but also on the fact that if they are registered as a donor or if they have relatives registered as a donor, they may receive priority points towards organ allocation when they in fact might need an organ transplant in the future. Many of you might recall that Dr. Jacob Levy had come to our province-wide rounds in recent years to present on this very topic and showcase the great successes that they've had in Israel with increasing organ donation and transplantation as a result of implementing this reciprocity-based point system. So clearly it's been a success over there. Another well-known example of more locally, internationally, is the reciprocity-based strategy in the voucher program within the National Kidney Registry in the United States. So there is something called the standard voucher program, which is also a form of advanced donation. So this is when a recipient needs a transplant, but there might be, for example, a chronological incompatibility, meaning that a donor wants to donate in advance and then assign a voucher to a specific recipient with chronic kidney disease, so that in the future, when the time comes, they may then in the future receive a living donor kidney transplant through the National Kidney Registry. And NKR is quite similar to our KPD setup in allowing sort of national organ sharing across the country with living kidney donors. So the standard voucher program functions as an advanced donation mechanism, but there's also the family voucher program, which primarily exists for what we call NDADs, or non-directed anonymous donors. And this allows any individual who registers within the NKR as a donor, essentially an NDAD donor. These individuals can name 5 family members who are not in imminent need of a transplant, so don't have chronic kidney disease. But in the future, in the event that one of them may need it, one family voucher can be redeemed per donor for a future kidney transplant if required. So this sort of gives people the assurance that if they're donating their kidney as a non-directed anonymous donor now, their family will be taken care of. One of their family members will be taken care of in the future if they need a kidney transplant. So this has really led to a significant increase in NDADs, or non-directed living donors, and total kidney transplants within the U.S. National Kidney Registry. The question then has been posed, is this sustainable? If we have a bunch of people giving out family vouchers, and are we going to be at some point in a problem where a lot of people are using the family vouchers, and so therefore exhausting the supply of organs transplants that are available through the National Kidney Registry? And so there was a 50-year simulation study that was actually published a couple of years ago looking at the feasibility of this and looking at modeling out various pathways and what things could look like in the future. And ultimately it found that NKR should be able to sustain the redemption of an increasing number of vouchers under a wide range of possibilities, given the current growth in the living kidney donor program, as well as the anticipated ongoing growth of living kidney donation. And then finally, which is great for the United States, because ultimately there's a lot of issues with insurance coverage and costs and whatnot. The NKR has also instituted the Donor Shield program, which has been employed by the NKR to protect donors against financial loss and to provide life and disability insurance, as well as legal representation should they require it. So this is to point out that here in BC, we do have a reciprocity-based strategy to increase living kidney donation, but internationally, there have been much more bold strategies in the United States and in Israel that have resulted in an increase in organ transplantation and donation. And so this has sort of partly led us to where we are today with our BC initiative, which I'll go through shortly. From a legal perspective, the question is, when we're instituting reciprocity-based strategies, what are the legalities around that? And ultimately, is it legally permissible to institute a reciprocity-based strategy? Well, when we look at legalities, we're often looking again at the US because they did institute the National Organ Transplant Act of 1984. And this stated that it's unlawful for any person to knowingly acquire, receive, or otherwise transfer any human organ for valuable consideration for use in human transplantation. Now, valuable consideration here is not defined clearly in NOTA, so it's quite vague. But the term does exclude, they do specify that valuable consideration excludes reasonable payments associated with expenses of travel, housing, lost wages, etc. So they do acknowledge that the component of financial neutrality, and therefore, but they don't acknowledge outside of that what a valuable consideration may be. So for example, what do people consider a valuable consideration? Do they consider being gifted something a valuable consideration, etc.? So that's not stipulated, and they use broad language on purpose to sort of have a broad sweeping prohibition on anything that could be considered a valuable consideration. In Canadian law, our transplant activity is regulated provincially, and there's provincial legislation that bans the sale of organs and tissues across the country. And again, our provincial law across the board employs very broad language that prohibits any benefit from donating organs or tissues. So in general, in North America, we have a wide legal prohibition on incentives, and this is in an effort to preserve the idea that an organ donation is out of a gift of altruism and to strictly prohibit any form of commodification of organ donation and transplantation. So despite the fact that we have very broad language in the United States as well as in Canada to prevent any sort of benefit from accruing any benefit from organ donation, we have been able to institute various reciprocity-based initiatives like financial neutrality initiatives and like KPD, which we've already talked about. And these have been legally permitted without amending any existing laws. And these have been thought to be legally permissible. And so as a result of that, reciprocity-based initiatives are thought to be legally permissible under the current provincial and US national legislation. From an ethics standpoint, which is sort of my lens within transplant medicine, living kidney donation is often driven by the altruism of an autonomous donor. And so reciprocity-based initiatives simply uphold the fact that a donor is making an autonomous decision, and we're removing disincentives to the living kidney donation, thereby sort of respecting their autonomy and allowing a donor to exercise their right to donate a kidney. So clearly, we're promoting autonomous decision making with reciprocity-based initiatives. There is a requirement for rigorous informed consent to ensure that donors are fully informed of the specifics of these reciprocity-based strategies and make sure that they understand it in full. Reciprocity-based initiatives should theoretically apply less pressure to a donor in many ways. For example, when we look at the voucher system in the United States, this allows a donor to donate in advance, and therefore they have a long period of time to contemplate whether or not they want to donate because there's no imminent need. There's no person who needs a transplant right now. And so there's less sort of pressure and an extended what we call a cooling off period. And that's a term used by living donor programs to enhance consent because it provides donors with time to reflect. So for example, from an advanced donation perspective, that initiative would actually improve the informed consent nature of the process and therefore, again, respecting the autonomy of a donor. This reciprocity-based initiatives also uphold beneficence in living kidney donation. For example, again, advanced donation provides the possibility that may not be there in the future because a donor might be aging. They might develop comorbidities in the future that might preclude them from donating at that point. And so this ultimately upholds the benefit of living kidney donation in allowing a donor to do it now, and then in the future, potentially be able to, for example, for advanced donation, be able to allow their intended recipient to get a transplant. And then ultimately, finally, These reciprocity-based initiatives are intended to increase living kidney donation, and therefore they are supposed to increase the number of available organs for transplant. And this overall will increase our population health and do the greatest good for the greatest number of people. And so utility in transplantation is promoted, and then we work to find suitable organs for transplantation for our recipients who are currently waiting for transplant. So from an ethical lens, reciprocity-based initiatives are certainly ethically permissible as well. We just want to make sure that this is a removal of a disincentive for all reciprocity-based strategies and ensure that there's no incentivization occurring. And so all of this sort of got us to reflect and say, now here we are looking at international programs of reciprocity-based strategies. We've got a local reciprocity-based strategy of prioritization of prior living kidney donors on our deceased donor transplant waitlist. And we want to see now, what is the major disincentive that's affecting individuals who are already predisposed to living kidney donation from actually proceeding with the donation, and how can we address it? And so ultimately, what are donors worried about, and how can we apply some sort of reciprocity-based strategy to alleviate their concern within a reasonable lens? So we saw a theme emerging from the qualitative work that's been done through our program through various studies. So I'm going to highlight them through these patient quotes here. So a kidney transplant recipient through one of the qualitative studies said, I had family members that had young children, and at that time they had expressed that they wished they could donate to me, but they had to think about their own children, and the idea of them not being able to help their own children if they needed a kidney would be devastating. As a mother, I understand that feeling of wanting to protect your children, even if it is a what-if scenario. Further to this, a living donor from the Action Project looking at transplantation in South Asian communities. I donated to my older sister. I've got 2 children as well, and then a part of me was like, okay, well, what if they needed my kidney in that way later down the road? Through the Bridge Project looking at Indigenous patients in transplantation, a living kidney donor stated, when people found out that I was actually donating my kidney, the question I got all the time was, well, what if down the road your child needs a surgery and you don't have a kidney to give them? And then finally, another living kidney donor. After becoming a father, a lot of my everyday decisions are based on my children and their well-being. I believe that if a reciprocity-based strategy was in place, individuals would feel more inclined to move forward through the process of living kidney donation. So in this, we found that an important disincentive to living kidney donation is ultimately the concern that a loved one might require a transplant in the future. And this was causing significant hesitancy, or the potential to cause hesitancy amongst individuals who are already predisposed or who are already thinking about living kidney donation. So this brings us to the goal of Donate Now. As a part of the continuum of removing disincentives to living kidney donation, we want Donate Now to remove an important disincentive to living kidney donation, in that if potential living kidney donors are concerned that a family member or a loved one might require a kidney transplant in the future. And so this policy stipulates that a living kidney donor can nominate up to 5 individuals, one of whom would be given priority for deceased donor kidney transplantation in the future in the event of need. And so again, to reiterate this policy, any living kidney donor that comes forward to the UBC adult kidney transplant programs can nominate up to 5 individuals when they proceed with living kidney donation, and one of whom would be ultimately given a priority on the deceased donor transplant waitlist, similar to how prior living kidney donors are in the event of need in the future. And this is to remove the disincentive that people are concerned about family members or loved ones that might require a transplant in the future, that sort of what if scenario that they're concerned about. And hopefully will promote people who are already predisposed to living kidney donation to move forward through the process and actually proceed with donating now, as opposed to waiting for some potential time in the future that they might need to do it or might not need to do it. So in this program, who can participate as a donor? This is any individual being worked up for living kidney donation in British Columbia. A living kidney donor has to reside in British Columbia or the Yukon with an active BC MSP at the time of kidney donation. For a directed kidney donation, meaning that an individual is donating directly to an intended recipient, the intended recipient must be a British Columbia or a Yukon resident with an active BC MSP at the time of transplantation. Now, this is subject to change because we do have donors that come forward, for example, that want to donate to a recipient in Saskatchewan or Manitoba or somewhere else in Canada. And eventually, as other provinces get on board and potentially start up systems that are similar to this, we can stipulate that donors who are donating to individuals in other provinces are also able to participate in this program. But as of the beginning of the program, we're restricting it to people who are donating to intended recipients within British Columbia through directed donation. And then any living kidney donor who ends up participating in the kidney paired donation program through Canadian Blood Services. So for example, if they're immunologically incompatible with their intended recipient, they would be able to participate in this program as well. Because again, their recipient who's a BC or a Yukon resident would ultimately be benefiting in terms of receiving a transplant in the future as well through KPD. Who can participate as a nominee? So again, a nominated individual means one of those 5 individuals who's named by a living kidney donor, and one of them may receive the benefit of a prioritization on the deceased donor transplant waitlist in the future if they ever need a kidney transplant. So who can be nominated and who can participate as a nominee? So a nominated individual must reside in British Columbia or Yukon with an active BC MSP at the time of nomination and at the time of requiring a kidney transplant in the future. The nominee must not be at risk of requiring renal replacement therapy within 5 years, defined as a 5-year kidney failure risk of less than 5% using the KFRE or kidney failure risk equation. Now, the reason we went back and forth a lot on this and had lots of discussions around this internally, the reason for this is because, number one, we don't want to have a huge influx of nominees requiring a kidney transplant in the early stages of the program. The goal of this is to increase living donor transplant rates and reduce wait times for everybody, including our deceased donor transplant candidates. And we also strongly want to prevent any sort of commodification of this or potential commodification of nominations, and thus want to be strict about not allowing nominees to be anyone in imminent need of potentially requiring a transplant. And so individuals must not be at sort of a 5-year risk, a high 5-year risk of requiring renal replacement therapy in order to be nominated. And for populations in whom the KFRE is not validated, for example, people with high GFRs, there will be an expert external nephrology opinion obtained on the risk of requiring renal replacement therapy for that individual within 5 years to determine if they can participate as a nominee or not. Now, what is the process around nomination? The nominee, once nominated, a nominee must accept their nomination and complete their baseline testing. Baseline testing entails a creatinine and eGFR, a urinalysis, and a urine ACR within 1 year or 12 months of initial contact by the transplant program. If a nominee is deemed to be unsuitable because of an elevated 5-year risk of requiring renal replacement therapy based on their screening testing, a donor will then be given an opportunity to nominate an additional person in that spot. However, the donor will not be informed which specific nominee, obviously, did not pass the nomination sort of requirements, and that's in order to protect the health privacy of the nominee that is not acceptable. And a nomination cannot be revoked or changed once the nominee has been contacted to complete baseline testing and provide consent for participation. And again, this is due to the need to prevent commodification of nomination. And so once a nomination is made, it's locked in and it cannot be changed. That nomination would stay there indefinitely. So if the nominee is a minor, which may happen quite frequently when people are speaking about, as we already talked about, the concerns about their children needing transplants in the future. If the nominee is a minor, meaning under the age of 18, the donor will be informed that pediatric patients currently receive a priority as organ transplant recipients in British Columbia. And if the donor still wishes to proceed with nominating the minor, which we think many people will say, yeah, sure, they receive a pediatric priority, but what if they graduate from pediatric to adult care and they no longer have that priority? And so understandably, a lot of people will still want to name their children or name children as a nominee in this process. So if a donor still wishes to proceed with nominating the minor, the capable minor can accept the nomination, or a legal guardian can accept the nomination on their behalf. If the nominee is a minor, the nominee must provide medical documentation in the form of a physician attestation confirming the absence of structural or functional kidney disease. we're not going to be making children do blood tests and urine studies and whatnot. And also the KFRE is not utilized in pediatric populations. And so as a result of that, we are looking to just have a physician attestation. So for example, primary care doctor, stating that there's no known structural or functional kidney disease in this intended recipient, and that would be enough to be able to nominate a child in this process. Nominees may withdraw their own nomination at any time. Nominations have no cash value and they cannot be sold, bartered, or transferred to another individual, again, highlighting the prevention of commodification of nominations. And if a nominee dies or withdraws from their nomination, the nomination is null and void. So ultimately, how does a nominee receive their priority in the end? So only one nominee will benefit in receiving a priority on the deceased donor kidney transplant waitlist. And this goes to the first nominee who's in need of a kidney transplant, with the caveat that the nominee must be assessed by the transplant program and be a suitable medical, surgical, and psychosocial candidate for kidney transplant. And once a single nominee from the group receives a kidney transplant and the nomination is utilized for priority, the remaining 4 nominations are then void at that time. So very similar to the family voucher program in the United States, where only one family voucher can be redeemed per donor. It's the same here, where only one nomination can be redeemed per donor that comes forward, and then the remaining 4 are void thereafter. Now, that's again with the caveat that if a nominee qualifies for an existing priority, so let's say an individual comes up for transplantation, they're ultimately found to be highly sensitized, or they need a multi-organ transplant, or if they're a pediatric patient still, if that happens, then the existing priority is above the donate now priority, which I'll show in a second. And so the remainder of the nominations then remain eligible because they haven't actually utilized the priority of the donate now nomination. They've utilized a different priority. So how is this different from our current standard? As I already pointed out, these are our current priority groups within organ allocation on our deceased donor transplant waitlist. And donate now nominees would be at the very end of that in terms of their being able to receive a priority for deceased donor transplantation. So again, if a nominee was highly sensitized, required a multi-organ transplant, et cetera, anything that fulfilled these categories above the donate now nominee, then they wouldn't be utilizing their nomination priorities. So therefore, the remaining 4 nominations would still remain eligible in that setting. But this is where we intend to put our donate now nominees in terms of receiving a priority in our reciprocity-based strategy to increase living kidney donation. Now we've looked at some data, or we've generated some data on this by conducting focus groups, and this has been some work upfront to look at stakeholder opinions and potential impact of our policy. And so the PhD researcher with our group, Ratinder Kaur, has done an amazing job conducting focus groups that's been funded by the Transplant Research Foundation of the BC CDTRP venture grant. And the aims of this have been to explore the acceptability of the policy, the potential impact of the policy on these key stakeholders, and potential limitations to implementation and mitigation strategies. And so these focus groups have been conducted with relevant stakeholders, including prior living kidney donors who donated in the past 5 years, patients who are currently active on the deceased donor kidney transplant waitlist, and then eventually we will also be next looking at general community members of Indigenous, South Asian, and Chinese communities, and we'll be conducting those focus groups. But the first 2 focus groups with living kidney donors and patients on the deceased donor waitlist have already been completed. So in summary for this data, living donors and deceased donor transplant candidates have validated the concern that the potential need of a kidney for a loved one is a barrier to donation. These quotes highlight that. I've had a few people who have children who I know would want to donate to me, but they were concerned, what if they need a kidney or somebody else later on? And the living kidney donor also said, I do have the thought in my head that what if someone else needs it later in life? I only have 1 kidney to give. And so overall living donors and deceased donors also thought, deceased donor transplant candidates, also thought that they also were supportive of the policy and felt that it would increase living kidney donation. Directly quoted from one of the living kidney donors that participated, I think it will serve to increase the number of living kidney donors. Some of the key messages specifically from the living kidney donors is that Donate Now would put donors at more ease and allow them to make their decision about donating without worrying about the consequences of their decision to other individuals in the future. Donate Now would increase living kidney donation and promote earlier living kidney donation for recipients. And Donate Now may increase the number of non-directed anonymous donors who are coming forward. And so again, some of these quotes here from the focus groups. I'm like, even though I went forward with donating without, this policy being in place, had the policy been in place, I think it would have just given me greater peace of mind. And then another living kidney donor had stated, then one of my children, who was a young teenager at the time, raised the concern. And so then I put the donation process on hold. But had this policy been in place, I would have done it 14 years earlier than I finally did do it. So it would have definitely impacted me directly. For patients on the wait list, the most deceased donor transplant candidates were supportive of Donate Now. There were, however, some concerns raised from them regarding the priority assigned to an individual and that this may add to the wait time for deceased donor transplantation. And this was primarily expressed or specifically expressed by highly sensitized patients who already have a prolonged wait time and were concerned that sort of adding more people to the priority list might extend their wait time. As I showed you before, it won't extend their wait time because highly sensitized patients received a priority above sort of the Donate Now nominees. But also one thing that's important to note here is we do expect an increase in the number of non-directed anonymous donors, and that directly benefits the waitlist because the non-directed anonymous donors will kick off often a chain of transplants, and ultimately that comes back to the local waiting list. And so ultimately it's a living kidney donor directly to the wait list at the end of the chain. And so the hope here is that the total number of kidneys available will increase, and therefore hopefully reducing the waiting time for transplantation for everybody. And again, why we stipulated that people who are at high risk of developing end-stage kidney failure within a short time frame cannot be nominated, because again, we don't want to have a huge influx of nominees requiring priority on the deceased donor transplant list, and therefore disadvantaging people who are already on the transplant list and extending their wait times. But this is a valid concern, from kidney transplant candidates, and it's going to need ongoing evaluation of the impact of this on the wait list. And it's clear that the messaging of this policy to people, especially deceased donor transplant candidates who are on the wait list, is the messaging is really critical, and in terms of relaying the intentions of the policy and the specifics of it and the potential implications. So this is a pilot program initiative. This is going to be supported by the qualitative research I've already mentioned. There's a legal analysis that's ongoing by Megan Taves in Australia, who's looking at in more depth at the legalities that I mentioned earlier. An ethical analysis that'll be led by me and various other ethicists across Canada. And then an expert international review of people on either side of the fence in terms of incentives in organ donation, and so people that are very much fit in for that and against that, and just getting their opinion on this policy, and that's ongoing as well. So we'll be having an ongoing review by a multidisciplinary steering committee as well, with a formal 5-year review and reports. So this is a sort of pilot program for 5 years, and then we're going to take a look back and see have we made any changes in living kidney donation rates, living donor transplant rates, deceased donor transplant rates. What's our wait times to deceased donor transplantation look like now, and how has that changed? How many nominees have had to receive a transplant? And then also a qualitative assessment of patient views having participated in the program. And so again, the goal of the program is to remove this important disincentive to living kidney donation and increase the number of available organs for transplant. And so hopefully that reduces the wait time for everybody. The policy will be flexible, and as we evaluate the impact of this, and so we may end up changing stipulations or changing components of the policy at the formal 5-year review. And this will have to be sort of balancing feasibility and logistics while maintaining the integrity of our living kidney donor program. Our goal for implementation is 2025. Although this is the first provincial public sort of presentation of this concept, we've been in discussions internally about Donate Now for the past year. And so potential donors coming through our program in the past year may have heard about it in some fashion as the concept has been evolving. So we will likely extend this policy to include all living kidney donors who donated in 2024 as well, as this policy has been sort of coming to fruition. And we'll be implementing through an educational push through our donor programs, through our kidney care clinics to integrate it into the recipient education sessions and packages. There will eventually be a media campaign as well to disseminate the information with potential support from some of our institutional stakeholders that we've been talking to. And so stay tuned to hear more regarding the implementation of this. So in summary, living kidney donor transplant rates have remained stagnant despite evidence of safety for donors and improved health outcomes for recipients. Reciprocity-based strategies to increase living kidney donation by removing important disincentives to donation are legally and ethically permissible. Donate Now will remove an important disincentive to living kidney donation in British Columbia, and it is a pilot program initiative that will need to be reevaluated at 5 years to determine its impact and future directions. I want to acknowledge and thank my colleagues John and Gill, who've been instrumental in getting Donate Now off the ground and to the point now where we're looking at implementation, as well as Ratinder Kaur, who's been working on the qualitative research component of this, as well as helping with the policy development. So with that, I thank everybody for your attention, and I welcome any questions or comments. Thank you.
Thanks. I'll just remind everybody that if they have questions, to put them in the chat or raise their hand, and we can unmute you to have a dialogue. But so thank you. I think it's a great initiative, and one of the questions is I'm assuming this is province-wide.
That's right. Yeah.
Right. Great. Any questions from the audience or any additional comments that you wanted to make, Jag?
Thanks, Justin. Great job outlining a complex area and a complex initiative. I'm wondering if you can comment a little bit on, the discussions and the thoughts around, do we make this retroactive to existing living donors or not? Because when we implement this, you can imagine someone who donated 5 years ago who didn't have this benefit may be concerned or raise concerns around that. So maybe if you could just talk us through the thoughts around that.
Yeah, I think, again, in terms of preventing a huge influx of people requiring who have been nominated who might require transplant in the future, we want to avoid sort of that process. This is intended to remove a disincentive to living kidney donation. So people that have already donated, that disincentive obviously was not there and did not sort of prevent them from donating. And so this is not a reward for donation. It's not a retroactive reward. It's sort of it's meant to impact people who are already predisposed to living kidney donation, and they themselves otherwise would not have necessarily donated because of concerns for loved ones. And so we're just removing that disincentive for future donors. The reason why we're making it retroactive for 2024, as I mentioned, is just because there are a lot of people that have already heard about this in some form, and there's been lots of internal discussions, and with the Kidney Foundation of Canada that started in 2024, and so we don't want to discount those individuals that may have known about this in some fashion.
Yeah, no, I do agree with Jag. It has a potential to be. I mean, there's a person that we're seeing in CKD clinic who donated a kidney to his father 10 years ago, who has unexplained proteinuric kidney disease, which is likely familial or genetic, and so. Because we didn't know then what we know now, and what would we do for him if he continues to progress. So I think it might need a little bit of nuancing as well. I guess one of the other questions, and this is kind of a health economic resources, like the amount of resources that go into such a program for the return on, is there a way to kind of, and I know it's not always about the money, but it is about, like, we don't have a lot of human resources for all these things. And so what is the kind of activity required to both launch and sustain this program so that one can say that, yes, this is, and that, the value proposition is there.
Yeah, and I think, Adair, that's a very great point. This is going to be a huge administrative task, right? To not only coordinate the nominations, but also maintain the database of nominations and know where people are in terms of keeping track of their blood work and making sure that they are acceptable for a nomination or not. And ultimately, the answer is we're going to have to look at that sort of 5-year time point and say, what has the change in living kidney donation been? What has the change in transplant rates been? Have we seen an increase over the last 5 years that we could potentially attribute to this? And what have the costs been that have gone into the program? So there's various modeling that we can do, much like what they did with the NKR, to look at the voucher system and its sustainability over a 50-year period. But ultimately, I think that's why we stipulated sort of the first 5 years are going to be really crucial for us to understand the impact of this policy economically, as well as just in terms of clinically on improving our outcomes for our patients.
And Maggie Mansfield has a question. Will the nominee be nominated for their own lifetime?
Yes, they will be. Yeah. So as long as the nomination will remain active, as long as the nominee is still living, and then again with the caveat that if they ever need to utilize their nomination for priority, they have to be deemed to be a suitable transplant candidate by our program.
Right, which in itself incurs resource utilization and evaluation, et cetera.
Exactly.
Yeah, the resource issue is critical, right? I mean, and I think the other big piece that we're really thinking about is the messaging, as Justin alluded to in the talk. This is going to be something very different than what we've done in the past. And so in the past, our target audience has really been recipients, it's patients. So it's been a little easier to infiltrate our clinical algorithms to say, how are we going to educate patients about this? So we'll need to do that here. But now we also have a broader general public approach that we need to take, which I think has to be very thoughtful, so that it doesn't raise unnecessary red flags and is done in a way that articulates it clearly, but also simply. And so there's opportunities, I think, to have not us do it off the side of a desk, but to actually formally get people who are good at and professionals at doing that, and look at that. But so those are some of the pieces we're looking at as well.
Yeah, I mean, as you're talking and as we're thinking, many people give blood and plasma for various reasons, and so the notion, I think where we're going with this is, can you normalize kidney donation from the public by awareness of how safe it is, or much safer than anyone thought it was, benefit to society and others. And perhaps this is one piece of how that gets normalized, but it may not be the only way. But what if 700 people in British Columbia offered their kidneys to the people that are on the wait list? Like, what if that happened? I mean, there are 5 million people here. Could we accommodate it? Would it work? It's an interesting thing to think through if it became as okay as blood donation, right? And
yeah, I think that's the hope, right? I think if we look at the next phase of where living donation, could go, that's it. It's normalizing it to that level, and obviously with the caveats and the safety pieces, is that's always going to be there.
And this might be one way to make it okay.
Yeah, exactly.
Right, and having to invoke that nomination would be quite low, right? Like that would be interesting. Like the number of people that did this that would actually ever need it would be low, but it would be ultimately worth it.
Well, I think that's and I think it needs to be. That's why we, you have to be quite restrictive in terms of, you can't make it easy, because you want to make it really one for one, right? Somewhat.
Yes.
We each only have one kidney to donate, and so that's why we cut the nomination at one, right? Because once you've got one person. There's just another question from Nancy. Hey, is there written information about this program available at this time? If so, where can one find it?
Thanks, Nancy. Yeah, there's no specific information written at this time from an educational standpoint, but there will be. So stay tuned for that. We'll be disseminating that through the nephrology community as it becomes available when the program is ready for implementation and launching. So we'll definitely get that out to you. I also see it.
I think it's important, not like you said, it's a pilot project, and let's not get ahead of ourselves. Like one step at a time.
I think Monica has her hand up as well.
Oh, Monica, go ahead. Or is that a question? No, I don't see a hand.
Maybe not.
Okay. Anyways, it is bottom of the hour. I want to thank all of you for the work that you do, and Justin for really outstanding presentation, that clear delineation of the principles, the practice, and the data behind it. And I think that's really a testimony to the thoughtfulness that I think all of us in the province put into the way that we help to make outcomes better. So thank you very, very much for that.
Thank you, dear.
Great way to start the year.
Thanks, everybody.